So let's go to the most frequent type of breast cancer, or different subtype. The most frequent subtype of breast cancer, which is the hormonal dependent breast cancer, or ER positive, HER2 negative breast cancer. So this is also, and this the aim of this slide is just to tell you that this is also a very heterogeneous group of diseases. Some of these diseases, some of this type of breast cancer has a very slow progression, and patients are able to live with this disease for several years. And there is a part of it that has more alterations, more mutations, and that grows faster and behaves more like the HER2 or the triple negative. So there are very different subtypes within this ER positive as well. And I'll come back with to the figure on the right side of the slide. So endocrine therapy is the most important treatment for this subtype of breast cancer. And it's actually our first example of targeted therapy. So what is the target here? Is the estrogen receptor, or it can also be the hormones that link to the estrogen receptor. So our goal here is to block the link between the hormones and the receptor. So we can do that blocking the receptor. This is what tamoxifen or fulvestrant do. Or we can do this by blocking the hormones. And in young premenopausal women, the majority of hormones are produced by the ovaries. So the most important thing is to block the function of the ovaries. We have to add some other form of hormonal therapy when we do that. After menopause, when the ovaries are no longer producing hormones, the hormones are produced in the liver and in the fat tissue through an enzyme that it's called aromatase. And so the best and more efficacious way to decrease the production of hormones is to block this aromatase with the aromatase inhibitors. Okay, so these are the most important types of treatment for this subtype. And this is why what is recommended is to give endocrine-based therapy for almost all. There is just one situation where we should consider chemotherapy, and this is called visceral disease, visceral crisis. And I will explain to you what is this visceral crisis. But so the recommendation for this subtype is multiple lines of endocrine-based therapy, and only go for chemotherapy if there is no response, so if there is resistance, or if you are out of options. At a certain time, you are out of options of endocrine-based therapy. Now, what is this thing about visceral crisis? So, and you also have heard for sure about visceral disease or visceral metastasis. So visceral metastases are metastases in main organs like liver, lung, that can be dangerous, okay? But visceral crisis is a different thing. Just because you have 1 or 2 liver metastases, it is not worse than having 2 or 3 bone metastases. What is worse is if you have so many liver metastases that the liver is not able to function properly. The same applies to the lung. It's not worse to have 2 or 3 lung metastases, but if you have many lung metastases that do not allow your lung to function properly, that's what we call a visceral crisis. So it's very different, because this is another common mistake in oncology, is to think that when we have liver metastases or lung metastases, we always have to give chemotherapy. That is not true. You always have to give the most effective treatment, which is not always chemotherapy. But in some situations, when the organ is not functioning well, you need something that acts faster and chemotherapy acts faster. Okay, so in the first presentation of metastatic disease of this subtype, it's not very frequent that patients are in what we call visceral crisis. Nobody knows exactly the percentage, but in the different studies, it is about 10%, maximum 15% of cases. In my experience, it's even less, but let's say that 10% would be the indication. So why do I put this complex slide here? Just to tell you that as with all the treatment options that we have discussed previously, resistance also occurs with endocrine therapy. And this is just the way that the connection of the different stimulus go to the estrogen receptor in the bottom, the different types of endocrine therapy that you have on your right, and what can you do with these resistant mechanisms. So what we have developed was other agents that we combine with endocrine therapy to delay this resistance and make endocrine therapy more effective, but especially more durable in the effect of the endocrine therapy. So one of these agents, or the most important of these agents are the CDK4/6 inhibitors, or the cyclin, CDK cyclin, the cyclin 4 and 6 inhibitors. Okay, so these agents have become the standard of care for this subtype of breast cancer, combined with an hormonal therapy agent. So we can safely combine them with an aromatase inhibitor, with fulvestrant, and some of them we can also combine with tamoxifen, not all. And something that I have not mentioned for the other subtypes, but I'll mention specifically for this subtype, because hormonal environments are different before and after menopause, and are also different in men, and men can have breast cancer as well and can have metastatic breast cancer as well. So these recommendations that I will speak are for all, for women before the menopause, after the menopause, and also for men. Just that women before the menopause, we have to induce the menopause with these agents that I told you that block the function of the ovaries. Now, what is the mechanism of action of these CDK4 and 6 inhibitors? It's similar to chemotherapy. Their target is the cell cycle, but they function in a very specific part of the cell cycle where the cyclins that, let's say, regulate the cell cycle are involved. And not all the cell cycle or not all the cyclins, as you can see there, just the 4 and the 6. There are many more, but if they block all of it like chemotherapy does, they would be more toxic. So they only block the 4 and the 6. So think of them as the ones that regulate the watch. So they regulate the cell cycle, particularly the cell cycle of the tumor cell, trying to lower the cell cycle of the tumor cell because they are dividing themselves so quickly. Now, I'll show you some graphics, but again, the goal is not to overload you with data. It's just to show you what these agents have shown in the trials. That was really very, very important. So we see a consistent, in almost all the trials, a consistent reduction in mortality of about 30%, with a benefit of almost 1 year, between 9 months and 1 year, additional 1 year of life, okay? Some of them even more than that. In the upper part of the slide, you see a trial performed exclusively in premenopausal women. And in the lower and the right part, you see a trial very similar performed in postmenopausal women. And the benefit was the same. You see the curves separating. And what is important to look at is this absolute benefit of over a year of life with a good quality of life, because these agents do not affect negatively the quality of life. So what I wanted to show you in this graphic is here, the median duration of life of patients with this treatment. And you can see it goes way beyond the 5 years, right? 63.9, similar to the Cleopatra trial that I showed you in HER2 positive. So when I told you in the beginning that, or when we discussed about the complete remission and the long staying in remission, we are also seeing that with these agents. And many patients are either in complete remission or with the disease stable for a long period of time, okay? And they also live longer with these treatments. And it is important to realize that no chemotherapy is able to provide this benefit. And that's why we keep on fighting for this subtype that we base our choices in endocrine-based treatments and not chemotherapy. Now, I wanted to make a parenthesis again for something that we have lobbied together, and that was an advance and let's say a victory of lobbying and awareness. Before, a couple of years ago, it was very frequent to exclude premenopausal women from trials in the metastatic setting, okay? And you will still see in some of the trials I will show you that they were run exclusively in postmenopausal women. The same happened to men. They were very often excluded from trials of new treatments. And with the CDK4/6, you have seen, I told you there was a trial designed specifically to the premenopausal women. That was exactly the same trial as the postmenopausal and provided exactly the same results. And this has helped us with our continued fight not to exclude the premenopausal women from trials. And finally, in 2020, the FDA issued this recommendation telling industry, and this means also academic research, not to exclude premenopausal women or young women from trials, especially because since in the metastatic setting, what we will ask them, the first thing we will do is to induce menopause. They should not be cut off from trials, because if they are cut off from trials, the approval of the drugs will not be approved for premenopausal women, right? So I will not stay too long on this problem, but if you want to read this editorial that the FDA, together with some of us, wrote, I think it is important, not just for metastatic breast cancer, but also early breast cancer, about not excluding premenopausal women from trials. And there is a similar guidance regarding men, not to exclude men from trials with breast cancer. So moving on, continuing with the results of CDK4/6, something else that they provide is that they delay the use of chemotherapy. So this is another benefit, because if you have your disease well controlled with a good quality of life and you can delay the use of chemotherapy, that will be also an important outcome. We can also use these agents in the second line. So instead of being the first option, as a second option, and they still provide a benefit in overall survival. The relative benefit is still 30%, but the absolute, the magnitude of the benefit is smaller, because every time we go further down the lines of treatment, the benefit is always a bit smaller because the treatment, because the tumor becomes more aggressive, but they are still effective in the second line setting. And again, in this setting, no chemotherapy has provided this benefit. I'm not going to go into the details of the quality of life studies. I just put this here to show you that all these agents either improved quality of life or did not worsen quality of life. So none of the studies had a negative impact on the quality of life. So if we go back to this schema of the heterogeneity within the ER positive, HER2 negative breast cancer, let's look at it from the clinical point of view. So in your first treatment decision, there will be a small group of patients that would have this visceral crisis. And for those, we still consider chemotherapy. Perhaps there is a small group of patients, let's say patients with oligometastatic disease or very low burden of disease that were for a long period of time without disease after the early breast cancer diagnosis. Perhaps those, it's still good and appropriate to treat with hormonotherapy alone. But for the vast majority of these patients, because of this huge benefit in survival, what is recommended is to give hormonotherapy and the CDK4/6 inhibitor. Now, in some countries, because these agents are expensive, in some countries you don't have access to a CDK4/6 inhibitor. In that situation, your second best choice is hormonotherapy alone. It is not chemotherapy. And this is something also very important to advocate for. So the second best choice is hormonotherapy, not chemotherapy. Now, again, this complex slide is just to tell you that even the best drug has resistance eventually. So the tumor learns how to escape even from a CDK4/6 inhibitor. And these are the different mechanisms that we think are implicated in this resistance. But it's just to tell you that we need more options, because eventually the tumor will start to progress even with the CDK4/6 inhibitor. So what can we do after this? There are the most, or the oldest treatment that we have that was developed even before the CDK4/6 is everolimus, which is the inhibitor of another part of this pathway called mTOR. Okay, just simplifying, it is one of the mechanisms of resistance of endocrine therapy is through this PIK3CA AKT mTOR pathway, and we have different blockers of this pathway. One of them is everolimus, and everolimus has unfortunately a bad reputation because the first time it was developed, there was no sufficient care about the side effects and the possibility to prevent those side effects. So one of the side effects is mucositis, so sore mouth. And we have found out later that we can prevent this by using a specific mouthwash with steroids. And if we do this, the everolimus is much, much better tolerated. So it has a bad reputation, but I actually like this drug and use it very often. And it's a quite effective drug. But I do two things. I don't use the dose of 10 milligrams. I start with a lower dose, 5 milligrams. And I also do these preventive measures. One limiting factor always is that it's also costly. Now, about this starting with a lower dose, Now we have a trial that look into this option that some of us were already doing in the clinical practice, but this is a German trial that compared starting with low dose and then increasing depending on the side effects, or starting with a dose that is approved, which is 10 milligrams. And what they saw is that there was a huge difference in the quality of life, and that it was much better, no difference in efficacy, and much better if you start low and you increase only for those who are very well tolerated without the mucositis. So very often, again, this idea that we don't need to go with a maximum dose of all these agents. Moving on, this becomes a little bit more complex, as you can see on your left. It's the same pathway, but in a more complex way. And this leads us to another option that we have, which is alpelisib, that blocks this gene PIK3CA that is alterated, mutated in about 40% of these tumors, okay? So alpelisib is also an option, an expensive option as well, unfortunately. And there is a problem with this drug. So we have seen a benefit in the progression-free survival, meaning it delays progression for about 5 months. But unfortunately, this trial was not very well designed. Why? Well, first, it didn't include premenopausal women, just postmenopausal. Then it was not sufficiently powered to see the survival benefit. So it means that statistically, there is no benefit in survival. There is a change in the curves. So maybe if the trial was bigger, we would have seen a statistically significant difference. But as it is, we don't see it. But the most important problem with this drug is toxicity. And I'll teach you something important. If you want to know if a drug is toxic or not, don't look at those tables like the table in the left side of the slide, where they list all the side effects, and then they show you mostly grade 3 and 4. Because a grade 3 and 4 are, of course, more important side effects. But if you have a grade 2 side effect that is persistent, it still has a huge impact in the quality of life. Let's say that you have moderated nausea, but it's always there. For those of you who have experienced nausea, you know that you cannot function well, even with low-grade nausea, if it is persistent. And the same with low-grade diarrhea, right? So grade 2 diarrhea means that you have to go to the toilet 6 times a day. I think that is a huge effect in your quality of life, but it doesn't appear in those tables because it's not grade 3 or 4. On the other side, if you look at the other table that is on your right, you will see percentage of patients that needed to reduce the dose, interrupt the treatment, or give up of the treatment completely. And you see that with alpelisib, it's 70% of patients have to have at least 1 dose reduction or interruption, or have to stop the treatment. So when you look at a presentation of a drug and someone tells you it was manageable, be critical. Everything is manageable. It doesn't mean that everything is well tolerated, okay? And this agent is difficult. But there are things that we can do to improve the tolerability. So we can take care. We can also, and we should also use the steroid mouthwash for the sore mouth. We can use antihistaminics because it gives rash and hinching, okay? And we should follow very closely the glycemia, especially in diabetic patients, okay? Just a few notes about this toxicity. I'm sure you'll discuss more on the workshop on side effects. So what do we do afterwards? Well, we have many other options of endocrine therapy. Some are old drugs. It doesn't mean they are not good. They are very good, like tamoxifen is very good. And so the take-home message is use several lines of endocrine therapy before going for chemotherapy, and give the same options to premenopausal women for as long as you block the ovaries, and to men that they also need this LHRH agonist. So we have many options, fortunately, for this subtype of breast cancer. If I make my classification again, what is must have? Several endocrine therapy agents and several chemotherapy agents, because in the end, all of these patients will need chemotherapy. Extremely important to have CDK4/6 inhibitors. Good to have everolimus and alpelisib. Okay. Research. A lot of research is ongoing. Immunotherapy is also being evaluated in this subtype of breast cancer. Other agents, for example, for the AKT inhibitors, are also being evaluated, and also combination of different types of these agents are being evaluated. I will show you two of the most recent advances. One of them is a different type of endocrine therapy called an oral SERD. So oral SERD is fulvestrant is a SERD. What does it mean, SERD? So it's a modulator of the estrogen receptor, but it also destroys the estrogen receptor. Unlike tamoxifen, tamoxifen binds to the receptor, but it doesn't destroy the receptor. Now, fulvestrant is a very effective drug, but is an injectable drug. You have to have 2 injections, one in each butt every month. So it's not comfortable. So that's why for a long time we've been trying to develop oral SERDs or oral types of fulvestrant, right? And these agents also have something else, which I will not go into the detail, but I told you there is a new biomarker coming, which is the mutation of the estrogen receptor called ESR1. And it apparently, these oral SERDs are more effective in blocking the cancer, the tumor cells that have this mutation in the receptor. So the first phase 3 trial was this trial with elacestrant. That is one example of an oral SERD compared with other types of endocrine therapy. In this case, was patients who had already received 1 or 2 lines of endocrine therapy, and it also could have received 1 line of chemotherapy. And I have to tell you that the results were a bit disappointing. You can see here that there is not a lot of effect, and especially what we can see is that the time without progression is very low in both arms. So it's 2 months and 3 months, more or less. So it's not exciting, neither without or with this new drug. But it could be that when given earlier, these could be more effective. And so there are many other trials evaluating these agents in the earlier setting. These have, however, different side effects than fulvestrant. Fulvestrant, besides the injection, is very well tolerated. These agents have, some of them have cardiac side effects and also eye ophthalmology side effects. So always this balance, remember, between efficacy and toxicity. And finally, then, to answer Ellen's question, we have a new biomarker, let's say, because it is important to note that this HER2-low is not a different subtype of breast cancer, okay? It doesn't have a specific behavior, but it can be considered a new biomarker, a new target. So This means that the cells have HER2 receptors, but not sufficiently high to be considered HER2 positive, okay? And that's why we call HER2 low. Now, these HER2 low, they may or may not have ER receptors. If they have ER receptors and are HER2 low, which is, they are included in the subtype that we just discussed, the hormonal receptor subtype, hormonal dependent subtype. If they do not have hormonal receptors, they are ER negative, PR negative, and HER2 low, they are included in the triple negative subtype, okay? So it's a bit confusing, but I hope I can explain. So is this a frequent situation? Yes, because it may occur in these two subtypes, in the ER positive and also in the triple negative. So it could represent about 45% of breast cancer in the metastatic setting, which is quite a lot of patients. So if you remember from what I explained to you about deruxtecan, the antibody drug conjugate, trastuzumab being the antibody, and then transporting this very potent chemotherapy to the inside the cell. So now I will try to explain to you what is this bystander effect. What you see on your right is exactly what I explained to you in the beginning. It goes to the cancer cells, go inside the cancer cell, freeze the chemotherapy inside the cancer cell. But what happens is that that chemotherapy can go outside the cell and affect the cells that are neighbors. And these neighbor cells are not HER2 positive, okay? They are, let's call it HER2 low or even HER2 negative, who knows? But because it has been transported, the chemotherapy close to them, they also die. So this is called the bystander effect that we see with this deruxtecan molecule. And that's why it was explored also for HER2 low breast cancer. And now at ASCO, we had the presentation of this study that compared deruxtecan with chemotherapy for patients who had this HER2 low breast cancer and had received previously 1 or 2 lines of chemotherapy and also several lines of endocrine therapy, at least 2 lines of endocrine therapy, and one of them had to be with a CDK4/6 inhibitor, okay? So let's say that they were pre-treated patients. And everybody was very excited about these results at ASCO, because when you look at all patients or at the majority of the patients that were ER positive, they had ER positive disease, you see a benefit of 10 months. So 10 months longer without progression. So control of the disease for 10 months longer. But more importantly, when you look at the overall survival, you had also a benefit in overall survival of about 6 months, okay? So for this for the subtype of ER positive, HER2 negative, but HER2 low, we will be having now this new option after a CDK4/6 and another line of endocrine therapy, and even after a couple of chemotherapy lines that we can use instead of using another chemotherapy, and this will provide a benefit in survival. I will show you the toxicity and then I'll explain to you why I was very upset with the clapping at ASCO. Okay, I'll tell you what happened. So this agent and all the antibody drug conjugates, they are more closer to chemotherapy than to the antibodies, okay? the toxicity they have is more similar to chemotherapy. And it's not a neglectable toxicity, unfortunately. So having deruxtecan is not the same as receiving trastuzumab. Okay? Trastuzumab is very well tolerated. Deruxtecan is not so very well tolerated. So you can see there again, look at the percentage of nausea. 73% had nausea. Yes, it was not high grade, but it was persistent nausea, okay? Also, almost 50% had fatigue. Fatigue is an important side effect. If you are unable to perform your professional life or your activities, normal activities, right? It also gives loss of hair. In about 40% of patients, you have loss of hair. And also some others of the side effects that you have there. So it is not something that we say intolerable. No, not at all. But we cannot say that it's very easy to tolerate these agents, okay? Importantly also, they may have, explained to you in the beginning, they may have this toxicity to the lung that can be fatal. In this specific trial, 3 patients died with the pneumonitis, so the toxicity to the lung. This is another thing that I'll teach you. So when you see grade 5 toxicity, that means death, okay? So it's a very simple, it's a hiding way of saying a very severe side effect. Grade 5 equals to death, okay? So the reason why I was not very happy that everybody was clapping when this was presented at ASCO is because, yes, indeed, this is a great drug, very effective. It's great to have another option, and especially to have an option that improves survival. Don't get me wrong, I'm very happy with this agent, but we haven't seen any cure. All that we see in this trial is 6 more months of life. And I think that all of us, if we are saying, if somebody tells you, you have 6 more months to live, we will be grateful and happy, but we will not clap, right? And we will clap when someone tells you you can be cured with this agent. So, and also it is not a very easy agent to tolerate. So I think we have to continue to do research, to develop new treatments, and to improve side effects, to see what can we do to make this drug more tolerable, okay? So I wanted to tell you about interactions. This is something we don't always think, but as a patient, we are very often taking other drugs, right? Very frequent drug that we take is for acids, so protectors of the stomach, right? That we call their PPI. So the drugs that protect the stomach, like omeprazole, lansoprazole, and pantoprazole, all these drugs, they are frequently used by all of us. And yet they have an interaction with the CDK4/6 inhibitors. And I'll show you here a study that has shown that it decreases the efficacy of CDK4/6 inhibitors. There are other examples. So antibiotics and steroids decrease the efficacy of immunotherapy. When we combine tamoxifen with ribociclib, we can have a cardiac side effect. So when we use oral drugs, we always have to think that they have more interactions, and that even IV intravenous drugs may have some interaction with other medication. And what I didn't put here, but I want to call your attention, is that sometimes types of homeopathy or supplements or other, let's say, complementary therapies also have these interactions. So the main take-home message here is, please tell your doctor everything that you are taking, because maybe there is another option, to substitute that medication that doesn't have an interaction. For example, something else I'm remembering, everyone knows Prozac, right? But Prozac has an interaction with tamoxifen. So if you are on tamoxifen, you cannot take Prozac, but you can take another antidepressant, for example, venlafaxine, that it's Effexor. So these interactions are very important, and you should discuss, always tell everything that you do, even that you do some complementary things. There's nothing wrong in doing them, but we just have to double check if there is no interaction with the treatments that you are receiving, okay? And then I spoke of a lot of things, but I didn't speak about palliative care. And the reason why I didn't speak, it was because Marcia didn't ask me to speak. No, I'm just kidding. I spoke about a lot of things. I just didn't want you to forget about this, the crucial role of supportive and palliative care. And supportive care is what makes all treatments safer and more tolerable. So it's what we do to prevent nausea, vomiting, diarrhea, anemia, neutropenia. All these is supportive care, and it's crucial that we have it. Palliative care is control of symptoms, and this should be introduced very early on, right? It is not the same as end-of-life care, not at all. Palliative care is crucial, particularly control of pain and control of all the other symptoms. And it's very important, and it's a priority. And one of the other things we need to fight is for access to effective pain treatment. And I know you will discuss about accessibility, but I wanted to show you the world regarding access to morphine. Morphine is a very inexpensive treatment, but there are a lot of prejudice about the use of morphine or of opioids overall. And you see that some areas of the world, people are not having access at all. In other areas of the world, they are abusing this type of medication, right? And this is directly linked to this other map that shows people who die in pain. So cancer patients who die in pain. Maybe we cannot always avoid death, but we can almost always avoid pain. And this is not fair that in so many countries, so many people are dying in pain. So this is something else that we as advocates, we need to continue to advocate for. And my final 3 minutes is to tell you something about the Global Alliance, of which Europa Donna is a member. So we have created this, let's call it platform of not just patient groups, but patient groups, healthcare professionals, pharma, diagnostic companies, policymakers, everyone who wants to improve the lives of metastatic and advanced breast cancer patients can work together. And you have here the website. Please go and have a look at the things that we do. All that we do is to tackle these 10 goals. And I don't have the time to go into the details, but you can also use this charter that is translated in 17 languages. You can use it as a lobby tool in your country and say, this is what metastatic patients need, and this is what I need to have in my country for the metastatic patients. And finally, when you go to the website, please have a look at 2 of our awareness campaign videos. One, which is this year's campaign, is about the right to continue to work or to return to work if you are not working. And you know, there are a lot of problems for both metastatic patients as well as survivors to be able to retain their professional life. And the previous awareness campaign is about stigma, that you will also have a workshop. Perhaps Marcia and Barbara, you can show the video during the workshop about the stigma and what this gives to the patients. So finally, I hope that COVID allows us to be face-to-face again at the ABC meeting next year.